Welcome, everybody. My name is Sandy Butcher, and I'm the Chief Executive of the National Organization for FASD. And we're really pleased to have this discussion today because the NICE Quality Standard 204 is something that is near and dear to all of our hearts, I think, and the entire FASD community. We'll talk a little bit more about why that is and why it's so important. But we also recognize that the progress that we think that the NICE quality standard represents is only really possible when we work in cooperation between different groups, between the NHS and all different stakeholders. So having an open discussion about where things are at this point is the first step towards the next phase of all of this. So I am going to start just by giving a quick overview of what we're going to do today. And then we have a couple other speakers with us. Can I just confirm, can somebody tell me you're seeing the slides? We're good with that?
Yes, we can see.
Okay, fantastic. So here we are today. As I said, I'm Sandy Butcher, and I'm with the National Organization for FASD. We'll be hearing today also from Dr. Inyang Takon, who's a consultant pediatrician at QE2 Hospital, and she's a member of the National FASD Experts Committee. We're also joined by Róisín Reynolds, who's the strategic lead for population health in NHS Greater Manchester, and she's also a National FASD trustee. And also from Clare Devanney-Glynn, who's a parent who is also one of the leads behind the Spotlight on FASD podcast. I want to just say up front that all of the speakers today were members of the NICE Quality Standard Specialist Committee that worked on NICE Quality Standard 204, but we're all speaking here in personal capacities and certainly not as representatives of NICE. In the course of the next just under 90 minutes, we're going to first have a brief overview of what FASD is, an overview of the report findings and National FASD's call for action as a result of the report. We'll hear about why these changes matter from the perspective of a community pediatrician. We'll spotlight the progress being made in Greater Manchester on the NICE quality standard as an example of best practice. And then we'll hear reflections from a parent as to why these things matter, why it would help to have more done in a more cohesive and faster way. And we'll have lots of time for Q&A. We're going to try during the course of the presentations, if after each presentation you have specific questions just about that presentation, we will have a short time for questions, but what we're hoping is that we'll get through all of the presentations and then have a more general Q&A. Did just want to say up front to emphasize that in this session today, we're here to discuss the overall national picture. We know that there may be questions about what the report shows about different local areas. We'd be very happy to discuss what's happening in your specific area, but we might need to do that separately, and you can always contact us for more about that. As we realized, a lot of the participants today come from a wide range of backgrounds, and especially to all those of you who are here from the NHS, we'd like to welcome you. And we appreciate that you're taking time out of what we know are incredibly busy schedules to join us. So a very quick overview of what FASD is. FASD results when prenatal alcohol exposure affects the developing brain and body. It's a spectrum. Each person with FASD is affected differently. While more than 400 conditions can co-occur, FASD is at its core a lifelong neurodevelopmental condition. All people with FASD have many strengths. An early diagnosis and appropriate support are essential, especially for executive functioning. That's from a preferred UK language guide, which is something that we would encourage anybody working in this sphere to have a look at, as that was created with input from people with FASD and their families as to how they would like FASD referred to. It can be caused by any type of alcohol at any time during pregnancy. There's been no proven safe amount of alcohol in pregnancy. Statistics show that more people have FASD than autism, with a prevalence rate from a gold standard active case ascertainment study done by the University of Salford, which showed that between 2 to 4% have FASD. That was also, by the way, considered a conservative estimate given some of the limitations of the study. And it's important to note that rates are higher for children in care and among those who are adopted. So it's a big issue, and the policy has been waking up here in the UK. While the first FASD diagnoses were in the 1970s, the reality is that other countries have been decades ahead of the UK in both policy and funding and paying attention to the risks of alcohol in pregnancy and the need for FASD diagnosis and support. But we are very energized and excited by the idea that the UK policy is catching up. However, our new report shows that implementation is not necessarily keeping pace with policy. And we do understand this is a very complex time for NHS organizations, but our window on all of this is what's happening in terms of FASD, and that's what we're going to present today. So, as I said, while there's been decades of indifference, really, here in the UK, in recent years, policy has been catching up in ways that many of us who work in this sphere might not have even anticipated. And we considered that 2022 was the tipping point with the publication of the NICE quality standard on FASD. And I'll just highlight a couple of the key developments and the changes that happened. Particularly in 2019, Sign 156 in Scotland laid out new diagnostic guidelines. And Sign 156 is the basis for the NICE quality standard. NICE has accepted Sign 156, so this is now also the guideline across Scotland, England, and Wales. And we're hoping that Northern Ireland will come on board at some point, but at the moment they haven't. One of the key changes that Sign 156 has is that it states that prenatal alcohol exposure should be actively considered as a possible underlying cause for neurodevelopmental delay. That's something that I don't think has really percolated through the system just yet. It also has important changes in the diagnostic terms, and it's very clear on how a diagnosis should be made. And it should be the basis now per NICE for any program across the NHS in England, Scotland, and Wales. There was also a Department of Health and Social Care needs assessment for England in 2021, which outlined priority areas for work that included everything from the need for a robust prevalence estimate across England. It emphasized the importance of multi-sector working to support individuals through their life course. That phrase throughout the life course is very important because Sign 156 deals with children and young people. But we at National FASD have a bigger remit because little people with FASD grow up to be adults with FASD and they also need help. The needs assessment highlighted the need for better training and awareness and the better organization of services and the need to develop innovative approaches to support people living with the condition. So then came the NICE quality standard on FASD, building on this work that had been done previously. I think there's sometimes confusion about quality standards. They're different from guidelines. NICE quality standards focus on a few key priorities within a defined area of care that are most likely to need improvement, along with providing information about how to measure progress. Quality standards set out priority areas for quality improvement in public health and social care. So it's more than a guideline. It's meant to be something that helps to improve care over time with these measurable indicators. So the NICE quality standard 204 on FASD identifies areas for improving the quality of care regarding FASD in terms of prevention, diagnosis, and management. The first statement in the quality standard is about advice on avoiding alcohol in pregnancy, and it says that pregnant women are given advice throughout the pregnancy not to drink alcohol. Note, it says throughout pregnancy. It's not just at a booking appointment. It says that quality standard statement 2 is about fetal alcohol exposure. It says pregnant women are asked about their alcohol use throughout their pregnancy, and this is recorded. Why do these two statements matter? Because FASD is preventable. Implementing the improvements called for in statements 1 and 2 of the quality standard could reduce the numbers being borne with FASD. This in turn would reduce the potential cost of FASD, as it has been highlighted in the needs assessment, is quite a large cost to society. Statement 3, and I'm simplifying these two. There's more in each of these statements, but for purpose of time, I'm simplifying. These are just the headlines from the quality standard. Statement 3 talks about referral for assessment, that children and young people with probable prenatal alcohol exposure and significant physical, developmental, or behavioral difficulties are referred for assessment. Statement 4 is about a specific neurodevelopmental assessment, saying children and young people with confirmed prenatal alcohol exposure or all 3 facial features associated with prenatal alcohol exposure have a neurodevelopmental assessment if there are clinical concerns. And statement 5 talks about management plan, where children and young people with a diagnosis of FASD have a management plan to address their needs. So it goes right from beginning of the first booking appointment through to management of care. Why do the statements 3 to 5 matter? Because implementing improvements called for in statements 3, 4, and 5 could help ensure that people with FASD are properly assessed, diagnosed, and supported. This too would reduce the potential costs of FASD as highlighted in the needs assessment, because people with FASD are already in the services, but without diagnosis, the funds are being used inefficiently. And that comes at great cost, not just to the NHS, but also to the people with FASD and their families and communities. Running throughout the quality standard, there are also statements that say that there should be training for GPs, community pediatric services, child development centers, and CAMs. It talks about the importance of multidisciplinary teams with expertise in FASD and the need for referral pathways. All right, so that's the background. Now, what have we done with the report? The report shows clearly that there have been some pockets of progress in the 2 years after the NICE quality standard. And yet, our research found that there are unclear lines of responsibility between ICBs, or health boards, and the NHS trusts when it comes to FASD. It showed systemic confusion within services inside NHS trusts. It showed a nearly universal failure to track the improvements in services over time on FASD using those NICE quality standard indicators that run through the whole thing. It showed a failure to provide FASD training across the workforce. And people with lived experience say this failure to act has terrible impact. Now, these are obviously broad statements, and this is just the overall picture that emerged. It's not to say that this is the situation everywhere, but nor is it to say that we can ignore the fact that this is the overall picture. How did we find this out? Well, we sent Freedom of Information requests about NICE Quality Standard 204 to all NHS integrated care boards in England, all the health boards in Wales, and all the NHS trusts in England and Wales. Keeping in mind, again, the reason why we focused on England and Wales is because that's what the NICE quality standard applies to. We sent an additional request about FASD commissioning and management to all ICBs and health boards. Just as a way to, I should say up front, we're a very small organization. We have 2 full-time staff and some part-time staff. We did the best we could, but we had to somehow limit the amount of data we were dealing with. So we chose If you're familiar with freedom of information request, there's a 20-day statutory deadline at which time bodies are meant to reply. So we use that as our cutoff for all of our freedom of information requests. But we understand that there are places that are marked in the report as not having replied who have since replied. And what we've done in the report, the PDF links to any responses that were received along the way. So all of the responses are able to be seen in the report. We tried to determine, first of all, if the relevant bodies consider the nice quality standard relevant. We tried to determine whether or not they've initiated action to track improvement in their quality of services, and also if they've commissioned services for diagnosis and management for people of FASD. And we, though the nice quality standard deals with young people, we asked about the commissioning across all ages. We rated the responses on a RAG system. If there was a red response, it showed that they did not demonstrate action on the quality standard 204. This could include some trusts or ICBs or health boards who considered themselves compliant, but who might not be implementing changes as called for in the quality standard. Perhaps they might not be using the indicators provided by NICE to track improvements, or maybe they might not have covered all 5 statements. An amber rating was given if there was partial action, but perhaps they might not have considered all 5 statements in their response. Green was given when they've demonstrated some sort of systemic and ongoing action, typically across all 5 of the statements. We believe that no ICB or trust or health board can claim to be fully compliant with the quality standard if they are not also tracking over time the provided demonstrable indicators to show how they're improving their services to meet the need. Using a quality standard is meant to be a dynamic exercise, and I know, and other people who were on the committee will reinforce this, that a large part of what the committee's time was spent on was not putting anything into the quality standard that could not be tracked over time using specific indicators. So if an entity had written back saying, yes, we're compliant with this tick, that wasn't good enough for our purposes because it wasn't showing that this is going to be revisited and using those indicators provided by NICE over time to show how the quality of services are improving, because that's the whole point for the NICE quality standards, to show improvement in the quality of services. The report's meant to be used to inspire change. We recognize and we work with people of goodwill throughout the NHS who are trying hard to improve services in a difficult climate. If I could underline that and come back to that repeatedly, we are well aware that this is a difficult climate out there. Our exercise is not meant to be anything but to help give some information that can hopefully aid people as they're trying to improve services. Our aim is to draw attention onto how the quality standard can help improve the health of the nation and the lives of some of society's most vulnerable. And as I've mentioned, we've included the full responses via link in the report. Actually, in the report, the reason why the report is as long as it is because we put verbatim responses received by the 20-day deadline. Some places did include some additional attachments and statements and charts. Just for reasons of space, we weren't able to put all of those in the report, but they can be found if you go to the links. We used an online portal called What Do They Know? And those the responses to the Freedom of Information request are all public on that website, so people can see it. We hope to spur creative thinking from leaders in different areas to see what others are doing or not doing in response. So we're hoping that different places will look and say, oh, that's interesting that, this area is doing that. Maybe we could learn from that. We are quite realistic and humble about the report's strengths and also the report's limitations. But we felt it was critically important to get a first attempt at the national picture. We recognize the limitations of judging solely on the responses received, as opposed to checking this against patient experiences or other measures. Any sign of action, task and finish groups, efforts to review policies, discussion of training, attempts to track indicators, these are all accepted at face value and welcomed as initial steps towards improvement in quality of care. As I said, we present this report with positive intentions and stand ready to work with relevant parties, other organizations, and anybody who's interested to help improve the quality of care. This report, this chart is in the report, but basically the key figures here are when it came down to it and after analysis, the integrated care boards in England who responded by the statutory deadline, there were about 53% of them that did not demonstrate they were taking action. And then when the health boards in Wales did better, they were all taking either partial action or taking action. The NHS trusts across England and Wales, we had about 56% of those demonstrated in their responses that they weren't taking action. So the good news is that there are areas who are taking action, and even partial action is better than it was a few years ago. But the cold reality is that there's still many places out there who haven't taken on board Nice Quality Standard 204, haven't understood that this does apply to their services and to their ICB or health, well, their ICBs. So there's still more that needs to be done. And then, as I said, we weren't originally going to ask the question about commissioning, but so many of the responses started to come back saying, from the ICBs, saying that this is something for the trusts, and then the trusts were saying, yeah, but we're not commissioned. So we decided to actually ask the ICBs and health boards if they're commissioning for diagnosis and management of people with FASD. And there's where the stark reality really comes in, because by far most areas are not commissioning for diagnosis or management of children, young people, and adults. And again, while we understand that the quality standard and Sign 156 focuses on children and young people, we as a national organization have a mandate to support all people with FASD. And I would just like to underline that, adults with FASD, most of whom are undiagnosed because they grew up in an era where FASD wasn't recognized, they are out there struggling without diagnosis and without FASD-informed support as a result of that. These are just a couple of quotes. One place warmed our hearts and said that quality standards are intended to drive up the quality of care, and so achievement levels of 100% should be aspired to. This is most certainly the goal. But the reality is that more places said we don't have evidence that Nice FASD quality standard 204 has routinely been included in decision making. Others gave replies such as this one that said our trust provides healthcare for people with serious mental illness, learning disabilities, and autism in inpatient and community-based settings. As a mental health trust, we do not provide services regarding FASD. And we would say back, if you go back and really look closely at what the Nice Quality Standard is saying, at the call for training across services, at the need for management of care, all of these sorts of services have a large proportion of people with FASD in there, diagnosed and undiagnosed, and it's absolutely an issue for mental health trusts. Another place said that standards 3, 4, and 5 are not relevant to this trust. This was a reply from one of the largest and busiest acute hospital trusts in the UK, whose services include a children's hospital, children's neurosciences, occupational therapy, speech and language therapy, physiotherapy, autism, ear, nose, and throat, endocrinology, genetics, learning disability services, and more. It's simply impossible that a trust with all of those services is not being seeing people with FASD, and that those 3 statements are not relevant to the trust. And then you get feedback from people with FASD who feel almost invisible. They're in these services, they go to appointments, people don't understand or recognize what their challenges are. There are families out there who are struggling to try to get a management plan and strategies. They say they're crying for help and they meet a series of closed doors. This has tremendous impact, and the nice quality standard 204 was intended to change this. So it's not enough for trust to just tick a box and say this isn't relevant to us. They really have to question themselves. And the ICBs need to see what they need to be doing to oversee this. And we would also argue that it's also a question for policymakers in the capitals and who need to look at some oversight on this to make sure that these things are happening. There are pockets of progress. Greater Manchester, we're going to hear about in depth in a few minutes. They're embedding work on the nice quality standard in key planning documents and really trying to address things across all of the statements. Hackney have an audit, and sorry, there's a typo in there. They have an audit and they have a training program that they're starting. This has been led by public health and elected officials. We're not saying that all of this needs to be done solely from within the NHS, but certainly there needs to be dialogue across the NHS and public health. Sheffield have set up an all-age FASD steering group led by the Children's Safeguarding, and they have actions underway. South Tyneside and Sunderland Trust are actively using the NICE indicators over time. They're one of the few places that have shown that. They have a task and finish group. And these are just some examples. Other places are highlighted in the report. So final bit is just to say what National FASD is calling for. And we do this not just in this report. I was recently before the Health and Social Care Committee and said some of these similar things there. We want meetings between policymakers and people with FASD and their families. We want to see green papers looking into FASD prevention and response so that policymakers have some oversight into seeing how what's been called for in the NICE quality standard and other policy changes are being operationalized. We don't believe it's acceptable to say that there's no funding for this. We think that there should be an FASD prevention and response fund equivalent to at least 0.1 or 0.2% of the alcohol duty. This would put funding here at the level of other countries such as the US, Canada, Australia. We are well behind where they have tens of millions of dollars and going into these things from a national level, and it's simply not happening here, and it needs to. The money is there. It's just not being directed towards this issue. We believe that there should be an ongoing audit on the progress of NICE quality standard. We either, if we could get more funding for that, we might suggest that perhaps it was supported by NHS England. We could do it in partnership with universities, maybe with NHS England itself, and do a more robust version of what we've just tried to do here. And we think there should be national guidance, oversight, and funding for FASD training across all health social care. We would also argue education needs training. It's being done for other conditions, but not for FASD. So that's the overview of the report. I don't know if there's specific questions on this right now, or if we might like to hear from the other presentations. Is anybody seeing anything in chat? Should we just go on to the next presentation then?
Yes, I think we'll have to go to Róisín next. Inyang isn't here yet.
Oh, okay. So Róisín, would you like to introduce yourself and then maybe show what Greater Manchester's done?
Yeah, no problem.
Thank you.
So, as Sandra said earlier, my name is Róisín Reynolds. I'm actually the strategic lead for alcohol harm for the Greater Manchester ICB. And I've been in this role since the ICB actually started in October of last year. But prior to that, I worked for the population health team within Greater Manchester, and I was a senior advisor for alcohol exposed pregnancies. So we're going to talk now about how we've responded within Greater Manchester to the nice quality standards. But what I will say is that obviously I was in a post as a senior advisor for alcohol exposed pregnancies from September 2018, and we actually launched our program in May 2019. So some of the work had already actually started prior to that date. I don't want people to think we've managed to do this in 2 years, because we certainly didn't. And we still have a way to go. We're not doing everything. Okay, Katie. So in relation, I'm just going to go through each of the 5 statements and then kind of expand on them as I go along. But if anybody's got any questions, please do ask. So for the first statement, we actually worked quite closely with our strategic clinical network in relation to maternity, and we co-produced a standard maternity alcohol exposed pregnancy operational policy that ensures that alcohol use is discussed and documented on 3 occasions throughout the pregnancy journey. We've got 7 maternity sites across GM, and then this policy is now overseen by the strategic clinical network. We commissioned CPD accredited AEP and FASD training that all health and social care staff across GM have been encouraged to access. We have been commissioning that training now since May 2019, and it was commissioned up until recently, until March 24. I know it's hard to believe, but we're in September and we still haven't had our budget signed off for this year, but we are hoping to commission another 11 sessions for the rest of this year. These have been extremely well evaluated. We initially started face-to-face, but then as COVID hit, it moved into the virtual world. And actually it's remained in the virtual world since, one, in relation to costing, and also we can get more people into a room. Alcohol exposed pregnancy pathways have been included in the GMEC Equality and Equity Action Plan. So for people that don't know what that is, this was a national requirement for every maternity area, for every authority, to actually write an equality and equity plan to ensure women who were vulnerable and pregnant were actually given the best care possible. What I will say is that Greater Manchester is the only area that included alcohol in their action plan. Alcohol exposed pregnancies and FASD was also included in our Best Start program plan. And we have an award-winning Dry-Mester media campaign, which is a website, social media platforms. And again, that was commissioned until March 24, but we continue to work with C21. And as soon as our finances are signed off, we will be continuing with that. If you haven't had a look at Dry-Mester, I would absolutely encourage you to do so. It's been very, very positively received. We actually did some evaluation. So we did a kind of a pre-evaluation with a research organisation before we did anything across our pilot areas, which were 4 of the localities of Greater Manchester. We then delivered a 10-week programme, and when the research team went back in again, there was evidence actually that the awareness campaign had improved awareness around alcohol exposed pregnancies and FASD. Statement 2, Katie. So the next slide, thank you. So women are given advice throughout the pregnancy not to drink alcohol. Again, this the standing operation policy will cover this, and the training that we've done will also cover this. Initially, the training was delivered primarily to midwives, and all of the midwives across our 4 pilot areas, which were Oldham, Rochdale, Bury and Tameside. For those of you that do know Greater Manchester, all of the midwives received training. Again, we included everything in the Equality and Equity Action Plan. We're in the Best Start programme, and we've got Dry-Mester. So we're very much covered in relation to Statement 1 and 2 in relation to during the pregnancy journey. Okay, Katie. So for Statement 3, children and young people with possible prenatal alcohol exposures referred for assessment. We have worked very, very closely with the School Readiness Board, who were very much on board with the work that we were trying to do. And we were able to ensure that staff who worked in early years were offered the opportunity to access AEP and FASD training. So we had 20 face-to-face sessions and 32 virtual sessions delivered up until June of 2020. And in the previous 12 months from 2020, over 1,000 professionals had accessed that training in the previous 12 months. And as I've already said, it's extremely well evaluated. We've used the same training provider throughout the whole of the 5 years that we've been doing the training now. It's an organisation called Red Balloon Training. We thought it was really, really important that we continue that for consistency, because we wanted to be ensure that, for example, if somebody saw a health visitor in Wigan, they would be given the same information as somebody who might see a social worker in Bolton. So it was really important that the same messages were always being told. So C21 are the company that our media company that do all of our trimester, and as part of our contract with them at the very beginning, their staff needed to come on the training. We have done some work with Oldham Theatre Workshop, and again, as part of their contract, they needed to go on the training as well. So we ensured that everybody who was involved with the program was trained in the same way and being given the same information. We developed a speech and language therapist FASD podcast last year, and we also commissioned some specialist speech and language therapy training. And these sessions were delivered in January and May of this year. So about 50% of the speech and language therapists across Greater Manchester have now had specialist training in relation to FASD. And we thought this was really important because often the speech and language therapist is the first professional outside of the GP that a child may well see because they have delayed speech. We are hoping this year to actually commission a podcast for, that says occupational health, but it should actually say occupational therapy. But we're hoping to commission a podcast for occupational therapy. We also supported GP Excellence in developing an FASD primary care podcast with a leading clinical expert, Professor Raju Mukherjee, and that's actually been downloaded nationally over 17,000 times. And that's available for anybody who's working in primary care. And it looks at the difference between autism, ADHD and FASD, and getting people to kind of be aware that somebody may well be presenting in what they previously thought might be autism and ADHD, but because there is similar symptomology, actually, it may actually be FASD that they're looking at. Statement 4, Katie. So children and young people with confirmed prenatal alcohol exposure or all 3 facial features associated with prenatal alcohol exposure have a neurodevelopment assessment. So we have commissioned Surrey and Borders NHS National FASD Clinic, so that's Raj's team, to deliver FASD training by 2 days. And the second of those were delivered in January of this year when 21 community and hospital-based paediatricians attended. And that was a really positive day. And I went towards the end of the day and I was asking the paediatricians if they felt confident now in diagnosing. And they were certainly saying that they did. But actually, what came to the fore for them were the number of children they had potentially diagnosed with either autism, ADHD, and they were wrong. And quite a lot of them were interested in going back and maybe reviewing some of the diagnoses they had already made. And certainly we've had feedback to say that that has happened, and those children's diagnoses have now been changed to FASD. We've commissioned the National FASD Clinic to provide consultation and clinical supervision to clinicians until March 25. We did this really because this again is Raj's team. We thought if we're training paediatricians to actually do diagnoses, then where were they going to go if they needed some clinical experts or they needed some feedback? So we've commissioned Raj's team to deliver some virtual online consultation and supervision clinics, and that's open to either individuals or it's open to teams, and it's actually been very, very well received. They've actually delivered more sessions than we've commissioned them to because they're not very good at saying no, which is obviously quite a benefit for us. But it's really good that people are reaching out going, we're worried about this child, or actually we've done a diagnosis and we're not sure it's the right thing to do. Developing a pilot FASD diagnostic pathway has been agreed in principle, but it hasn't been taken forward. So these are ongoing discussions that we're still needing to have. We have commissioned an 18-month support package until June 25 with National FASD to support families across GM who care for children with FASD. And again, this was on the back of bringing Raj's team in to do some diagnosing. We thought if there are doctors and teams diagnosing children with FASD, they need to have somewhere where they get some information that they can give to families as to where they can get some ongoing support. So it felt really, really, really important that it was all part of the package of training our clinicians across GM. And our next slide, Katie. So for the final one, really, children and young people with a diagnosis have a management plan to address their needs. So I attended a roundtable facilitated by National FASD to discuss what's needed to be included in a management plan. And we're hoping that the support package being offered by a National FASD will empower families to be able to ask for a management plan as they need them. But this, again, is another area that we still need to do a lot of work in. Next, Katie. So outside of the actual quality standards, how we've ensured that we can keep the quality standards actually on the agenda is that it is actually a priority for our alcohol harm programme within the Greater Manchester 5-year plan, which was developed this year, 24-25. So that ensures that AEP prevention remains a priority for Greater Manchester. It means that we can ensure that there is the implementation of the prevention pathways across all the Greater Manchester Maternity Services. We're testing potential approaches to meet the requirements of quality standards 4 and 5, which relate to the neurodevelopment assessment and the development of implementation of management plans. We're absolutely committed to continuing workforce development and sustaining and developing Drimester and sustaining and developing further the work that the GM FASD network is actually doing, because we've had lots of positive feedbacks from families in relation to them wanting that support. Something I probably should have stated at the beginning is, so originally when we were commissioned as an alcohol exposed pregnancy prevention programme. And we very much sat under population health, which is a prevention programme. But what we learned very quickly is that you can't talk about alcohol exposed pregnancies and not talk about fetal alcohol spectrum disorder. So we worked with a group of parents from very, very early on, that they were our parents as partners. They were involved in all of our decision making. They sat on all of our interview boards. They came to all of our network meetings. They sat on all of our steering groups. And I think the most important thing is they were our critical friends. They had a voice in the room. And if there was something they weren't happy about or something that they felt needed to change, we very much took that on board and worked alongside that. And I think that's probably one of the reasons why we have been the most successful. And it's probably the part of the role that I've enjoyed the most and actually felt the most positive about. Next section, Katie. So the gaps in the GM response, as I've already said, I'm not lying, I'm not going to hide any of these. We don't have a formal FASD diagnostic pathway, but what we have, because Raj's team has now come in and trained 40 clinicians, we have pockets of clinicians across all 10 localities actually doing some diagnosis. And we are hoping to commission Raja to come back and deliver training to a further 20 practitioners within this financial year. We have no training available to staff to development management plans, but it is on our cards and it is something that we're working towards. But if one of the things that we have to ensure around management plans is that if we're training staff to actually support families in developing a management plan, these need to be implemented. And we're aware that that, again, is another stepping stone. So people have come out of Raja's clinic in Surrey with a diagnosis and gone back to their own area. And then being asked, well, who's Dr. Margaret Mukherjee? And we don't know him, and he's not a local clinician. And no, we're not going to do what he says. What he says we need to do, because we can't. We haven't got those facilities. So it's really important to actually keep the momentum going. And I think that might be all my slides, is it, Katie? I think I do have some questions. I think one thing I'd like to say on that as well, and I hope it's come across, that I'm very passionate about this piece of work. And certainly within your locality, that's what you need. You can't have somebody where this is an add-on to an already busy job. And I think a really fantastic representation of that is the work that Mandy Craig has done over in Sheffield. I don't know if Mandy's on the call, but Mandy got involved in FASD through a small part of her work. And actually, if you look now over the 3 years, what she's managed to achieve because she had a passion for it. And another experience that we've had in Greater Manchester is we went to lots of the boards. We went to the CAMS boards, we went to the mental health boards, went to the learning disabilities boards, went to the early years and readiness boards. We spent quite a lot of time in the first year, and everybody agreed that something needed to be done. But what people couldn't agree on is whose responsibility it is. And that's actually still going on. So it isn't something that's going to go away overnight. It isn't something that you're going to be able to say to somebody, I need you to focus on this for the next 3 months, because it's a long journey, and be aware of that really when you're starting your journeys.
Thank you.
Okay, I'll stop there. Is there any questions?
There's a lot of people wanting to move to Manchester after hearing your report there.
Right. You're very welcome. It's a great place to live.
Yeah, no, and we are all watching what's happening in Manchester, and are deeply appreciative of the work that you and your teams of people have been doing on it. Again, showing that things can happen even in a complex health environment, and that it does make a difference. I wonder, I have a short 4-minute video from our what we just did in Manchester on the 9th of September. I wonder if it might be nice to give people a break from all the talk for a moment. And I see Inyang has just joined the call. She was delayed.
No problem.
Clinic. So I'll show the video, and then we'll come to Inyang, and then we'll hear from Clare, and then there'll be more time.
No problem. Sandra, can I just answer one question before
Yeah,
while
sure.
you're setting the video up? Somebody, Sarah, sorry, I haven't got my glasses on, Sarah, but I think it's Sarah Savika.
Sure.
What's a good place to start with replicating this? Is a question that you'd asked. If you have any funding at all, if you have any small pockets of money, I would absolutely say train your staff. You need to increase awareness. That's one of the biggest areas that we found was in relation to people then responding in a much more positive way when they actually understood what FASD was, and actually recognized that, especially if they were working with young people services anyway, that potentially they were working with young people with FASD. They just didn't know that they were doing that. But I'm going back to the point that I made earlier. If you've got somebody who's passionate about it, get on board with them and support them to actually take this forward on your behalf. So I hope that answers your question.
Thank you.
Yeah, you've got a couple other questions that have come now. I do want to make sure we get Inyang and Clare in before we get too deep into all the questions.
No problem. That's fine.
There's a question about social worker training and whether most of the clinicians are taking time out of their existing job plan to do the FASD work. So there's two separate
all of the training that is available has also been made available for social workers, and yes, we've had a number of social workers have accessed the training, and we have actually also been to all of the social work boards across GM as well. It did take us longer to actually get them on board than it did our health colleagues, but yes, they have come to the table. I think I suppose it depends. When at present, most of the clinicians involved in taking time out of their existing job plan. I don't necessarily think they are, because I think a lot of them are already working with children who have got FASD, and as I've already said, they're not aware of that. And actually, the issue with this, and when I've talked about the consultations and the training, there was a situation where there was a child being treated for ADHD on physical medication, and they weren't responding, which they won't necessarily do because some of the medications work on the frontal lobe, and it's the frontal lobe that's been damaged. But this child was then diagnosed as treatment-resistant ADHD and then referred to CAMHS and sat on a waiting list for 2 years, when actually the child had FASD. So they are there, and they're out there in the system already. And that's why it's really important that we're actually training staff around awareness, because if staff who are working with these young people are picking up, actually, this might be FASD, and then having the appropriate conversations, you wouldn't necessarily find those situations happening again.
Great. Okay, I'm going to just show this video because I think it's important in that what we tried to do when we were in Manchester for the 9th of September for International FASD Day, it was to try to show the scale of what we're talking about.
So today is September the 9th, which is International FASD Day, and we're here in Greater Manchester at Media City, Salford, to talk about the fact that there are 660 babies likely to be born in Greater Manchester with FASD. FASD is a preventable condition, so if people are given information and support about the risks of alcohol in pregnancy, then they can abstain for 9 months and be sure that their baby won't have FASD. So we've got 660 baby vests. Each baby vest is representing a baby that's likely to be born across this area in a year. And of course that's a conservative estimate, so there could actually be double that figure.
It's just seeing the physical evidence of this many, over 600 young lives, but not just the children themselves, their families, and the communities, school teachers. There's a lot of lives will be impacted by drinking during pregnancy, which is theoretically preventable.
I just found it really powerful and overwhelming last night as we were preparing for this. I mean, I do this all the time, and a lot of us do, but to sit in a room surrounded by these 660 baby vests, knowing, I just kept thinking of my son when he was little wearing these kinds of clothes and thinking that each one of these represents a life that's been affected forever due to the prenatal alcohol exposure. It really made it come home for me, and it's just vast and it's preventable. So I just hope that we can do more to raise awareness and to help create brighter futures for kids. But it's a powerful, I didn't think I was going to be affected as much as I am, and I found myself really very affected.
Alice. I am a mum to a 2.5-month-old baby, and when I was pregnant I was under a trust who have just announced that they would take an action against alcohol in pregnancy, yet throughout my perhaps over 10-15 appointments with maybe 10 and 12 different professionals, not one of them asked me about alcohol in pregnancy, whether I consumed alcohol, and also I didn't find out that I was pregnant until later on in my pregnancy. And actually when I went to that first appointment, they never said to me, have you drunk? If you have, maybe you need to look out for this when your child's older. And I also remember sitting in the pregnancy assessment unit, and they had a kind of screen which was showing adverts. They had one for domestic violence, they had one for kind of illnesses when you were a child, and they had ones against tobacco, but there wasn't one about alcohol and pregnancy. And that is from a trust who are claiming that they are making progress in supporting women with alcohol and pregnancy.
A lot of lives that we're talking about here, and the good news is that we can change their trajectories, and that's the hope. Inyang, I believe, is now in the call. Would you like to give your presentation? And we'll have Clare, and there we go. Inyang, please introduce yourself.
Okay, can everyone hear me? Can you hear me?
Yes, you can.
Okay, I'm so sorry for being late. Been in clinic and just managed to get out now. So I'm Inyang Takon. I'm a consultant pediatrician in community at East and North Herts NHS Trust, and this is my 20th year of being a consultant in the trust. When I say the numbers like that, it's frightening that I've been here for 20 years. But I'm one of the neurodevelopmental pediatricians, and I see children with a wide range of behavioral conditions, but got interested in FASD so many years ago, which I took an interest on a personal level, but then was trying to see it for assess patients, because these were patients that came to me in the clinic, and I then got more training through Raja's Place and through conferences that I'd been to and personal study as well. So I've been involved in this work for quite a while, and was also on the specialist advisory committee for the NICE quality standards, which we're talking about today. So that's a brief overview about myself. So I haven't been at the earlier presentations, but today has been about looking at what has happened since quality standards, and from a pediatrician's perspective, how have I seen it? So having known the issues that were present, which were the issues that we were happy were included in the quality standards, there's been a lot going on in the background. There's been a lot more education, a lot more awareness going on, but just looking at from our point of view and still looking at the patients that we see day to day that come to us, we're still having these problems of lack of information on maternal alcohol consumption during pregnancy in the neonatal record. So there's still a lot of, there's still limitation in information, and there's still times where we've seen children who most likely meet criteria, especially those without facial features, but there's all these suspicions and non-documentation of information, which then results in poor identification of at-risk infants. And there's still a lot to do with our neonatal colleagues working alongside the obstetric team to get this information down, but we're still not having that information. And therefore, when they're clear at-risk infants, they're not well identified and flagged up. And even ones that were known maybe to social care, we're still having this over and over again where there's poor identification due to poor documentation. And I've seen this a lot when I do safeguarding medicals, where you're going through the history, or the children who are looked after, and you're going through the history, you find that that information is not present. So quality standard 3 says children with significant physical, developmental, or behavioral problems who may have been exposed to alcohol before birth should be referred for an assessment by a healthcare professional with additional training in FASD. Now, I'm just looking at that quality standard. It's got several parts. So if we look at the parts saying the children should be assessed by healthcare professionals, now we're having problems with, so looking at this, we already know that neurodevelopmental services are receiving a large number of referrals with children with all these conditions, with physical, developmental, or behavioral problems. That's, if we look at a lot of the referrals coming in, several of them will have these problems written on the referral letter. But what is lacking is that those referral letters do not have information on exposure to alcohol before birth. So already the referrals coming into the pediatric team is already lacking in that information. And even when that's been present, we know that those referrals, a large number, are not being accepted even within those neurodevelopmental services. And again, we're saying healthcare professionals with additional training in FASD. So since the quality standards, there's been regular masterclasses held by the RCPCH to train pediatricians on assessment for FASD. And looking back, so many pediatricians have been through that training. Many have been keen to have that training. So we can say that a large number are being trained, and there's still holding. There's one holding in December. But we're not finding this being translated into services now accepting children for FASD assessment. So there is a gap. There's a gap in clear referral letters being sent to the services. And there's a gap where when you've got trained healthcare professionals, that those services are not reflecting the fact that they are now accepting these referrals for children with FASD. And this is happening when I speak to colleagues. These are the challenges that they're having, is that they're meeting this block where, the services are not, accepting these referrals as much as they should. So when children are then seen in the neurodevelopmental service, they're not intentionally being screened or assessed for FASD. Next slide, please. So now going to the assessment. So we know that QS4 says young people with confirmed prenatal alcohol exposure or all three facial features should have neurodevelopmental assessments. And they're quite clear about what neurodevelopmental assessments mean. It's assessments for those neurocognitive deficits that we are looking for in children who've been exposed to alcohol prenatally. Now, we know that when we're conducting clinical examinations, clinicians more or less they're doing the general and physical examination, but very rarely do you find the clinicians being intentional about actually looking at facial assessments as part of that, even in a general neurodevelopmental clinic. So I think what has happened is most services have been looking at FASD as if it's a big piece of work. It's a new piece of work. It's something that's very labor intensive and needing a lot of capital. But actually, we are seeing these children for neurodevelopmental assessments already in the clinic, and we're carrying out these physical examinations. So having to do a facial assessment and looking for all those kind of physical features when we're already doing it for, being intentional about thinking about FASD when you're doing those assessments is quite crucial. And I think this is what we need to be looking at. A lot of children that are being referred, there's a lot of referrals for autism, ADHD, there's pathways for those conditions, and more single conditions being referred for. And as a result of this assessment, children are seeing speech therapists, physios, OTs for different things. But it would be better use of, the professionals' expertise to actually engage them in looking widely, as considering if those same children they're seeing do have features that could, be suspicious of FASD, it would be good for them to carry out those assessments comprehensively. In that way, you're not getting them to go and see another speech therapy, another physio, another OT, because they would have done that in the context of their assessments. So it's very important that when we're looking at the way forward, looking at with the existing services we have, how can we engage all professionals so that when they're doing their neurodevelopmental assessments, they're already having an expanded view of the children they're seeing. Likewise, the educational psychologists. So we've got to approach schools when we need a child to see an educational psychologist. It's very, very difficult to get them to see. And many times when we want them to see children, we're not getting the kind of detailed, comprehensive assessments that we need in order to tease out the deficits in FASD. But this is something that we can overcome. We can have better liaison with the school team. We can have schools being part and parcel of this assessment so that when we're asking for educational psychologist assessments on children that we suspect FASD, the psychologists can do those neurocognitive assessments and help to look at those deficits seen in FASD. So I look at this QS4 as a place where we can have opportunities to look at what do we have on ground already and how can we get those professionals that we have on ground to be trained on FASD, to know what to expect in terms of assessing the children. And that's where QS4, we need to do a lot of work on. Next slide, please. So QS5, and then some of the difficulties some clinicians have is saying, okay, when we diagnose FASD, we don't know, they don't know what to do. Do they have a management plan to address the needs? We do address this during the master classes, when we talk about management and support. But we know that in most neurodevelopmental services, they have clear pathways for ASD and ADHD. They have management plans for them. They've involved schools. They're quite clear between them and schools. But we don't have that kind of system in existence for FASD. And this is what we need to do so that clinicians don't just feel, okay, I'm just diagnosing them, but I don't know how to support them. I think everyone needs to be able to have an idea from the beginning about how to make this quite visible and clear. Just like we have ASD and ADHD, we should be thinking wider that if we've got a child with FASD, what should we be doing from the point of diagnosis in supporting the child and the family? Next one, please. So the experience so far, and this is perspective from pediatricians, is that many children have had multiple assessments for other neurodevelopmental conditions without FASD being considered, and that's quite typical. So children I see, a lot of them have gone through the works, they've waited a long time. The waiting list now for us to have ADHD or for an initial assessment when a child is referred is about 2 years. So if you think of a child who's waited 2 years, and that's being quite optimistic, waited 2 years to get seen, and they're told, okay, you don't have ADHD, and then, okay, you now go and wait for ASD. Okay, you don't have ASD. That's taking a chunk out of that child's critical years where proper assessment and diagnosis should have been made and support given. So by the time the child is now being considered for FASD, which we know parents at that point are struggling even to get the service and the clinicians to do the assessment. So, and many times we find that it's the foster carers or adoptive parents who've heard about FASD, who know their child, who've suspected this, trying to seek help, have gone to look for assessments. And many times referrals are declined as the services say there's no commissioned service, there's no existing pathway, so referrals are declined. And then clinicians who have the training on FASD assessment do not have the relevant MDT support to conclude the assessment. So the speech and language, the psychologist, the OT, they do not have that support from the team. So even though they suspect it, they cannot, further that assessment and do the neurocognitive. And even when you say you want to send the child to a tertiary center to go and get assessed, very few children received approved funding to tertiary center to get this. So a lot of times there are many children who are going, just left out there, not being able to access the service locally, not being able to go for tertiary assessment. So it's quite, it is a very difficult situation. And when you finally get those children where you assess and you nail the you come and confirm the diagnosis of FASD, the families have been through a lot of trauma in that journey. Next slide, please. So neurodevelopmental pathways are needed rather than single condition pathways. And I feel that the ICBs need to support inclusion of FASD in the neurodevelopmental pathways, because if we start from that from the beginning and know that FASD is one of those conditions that we're looking at, rather than having so many pathways, we've got ADHD pathways, we've got ASD pathways, we've got all this. If we start from the position, let's look at neurodevelopmental pathways that include FASD, then people will be thinking about that from the beginning. We need to support MDT assessments by professionals to explore features that may be seen in children with FASD from the beginning. So if a child is being seen by SALT or physios, they need to consider that presentation and improve liaison with schools. And then services to include process for assessment of children with more complex presentations and referral to tertiary services. I think it's difficult where you know that if we've got a child where we're struggling to say, is this ASD, we can have a pathway to refer that child to a tertiary center. But if we've got a child that you suspect FASD, you do not have the pathway to refer. And I think this is something we need to look at if we're talking about equity for of service for these children. Next paragraph, next slide. So we know the consequences of delayed or no diagnosis. Like I said, there's a lot of trauma from children and families due to lack of right diagnosis and support. There's breakdown in placements, there's lack of appropriate or adequate support in school. There's mental health challenges for the child, siblings, and family. And the healthcare system as well becomes inundated with repeated referrals and reassessment.
Clare, Devanney-Glynn is also on the call, and Clare was, along with me, a lay member on the NICE Quality Standard Committee. Clare, I wonder, what's your reaction to the report and to what we've been talking about today?
I think, can you hear me okay?
Yes, we can. Go ahead.
I think it's very easy to be really overwhelmed and depressed by it and get angry. That it's easy to feel like that, but I know I am well an eternal optimist. But honestly, I've been through so much with my 3 children. So I am alone with 3 teenagers with FASD, and they are now 17, 18, 19. And the moving into adulthood and adult services is really started to focus me in a way that I probably haven't been focused since I was trying to seek out a diagnosis for them, 10, 12 years ago. But my overwhelming feeling still is, I never dreamed we would even be in this position now in 2024. It is beyond my wildest dreams from where we were to where we are now. And I know it's frustrating, and you think, but look at everything that's in place for autism, ADHD, learning disabilities. And when you live in this world, you become consumed by it and you can't help but be passionate about it. And you think, but we know that our FASD kids are just woven in amongst all of those children. And yes, they are. But I think that, I very rarely, in my professional capacity, I very rarely encounter a meeting now where we're talking about neurodiversity in any way where it isn't mentioned. And you would have fallen off your seat even just 4 or 5 years ago if it was brought up by a professional. So I really want us to stay focused on that. I feel like, the image of the man who's digging and digging away and he can't see where he's about to get to, and he stops when he was kind of one shovelful away from breaking through to where he needed to be. I feel like we are so close to being there. And certainly in I would say even the last 6 to 8 months, I have been contacted by so many professionals in primary care and mental health who are determined and focused and as frustrated as we, the families and carers, are about we've got nothing commissioned, we've got no pathway, what do we need to do, and trying to find ways around it. And they're really making the voices heard. And I would say a big problem, which I hadn't really given any thought to, I was speaking to a doctor who was able to diagnose, but what he was saying to me was, if we do this without any commission service at all, if we do it as an extra to what we're already doing, we will never get any funding to be able to do it properly. And so it's this horrible rock and a hard place where they're looking at these young children and thinking, we know exactly, effortless, we can give you this diagnosis, but they're loathed to do it a lot of the time, I think. And that's a view that I hadn't really given much thought to. If they start doing that without it being commissioned, that they're opening the setting a precedence, really. As a mum, I would think, well, I don't care. I don't care about any of that. I need you to be diagnosing, but that is the reality of it, I suppose. I think someone's got a hand up, Sarah.
Yeah, I just wanted to kind of echo what you've said, Claire. We're like a child psychology service in Staffordshire, and we kind of contacted local paediatricians and said, we can help with the neurodevelopmental side of the assessment, executive functioning, and other kind of aspects. We've got speech and language, but the paediatricians kind of said the same thing. They said, well, if we start doing that and it's not a commission pathway, we'll just get completely flooded, or it won't kind of be formalised. And I find that so frustrating, kind of coming across, so many of these children, that I feel that we've got the skills and the networks to do it, but we're just not doing it. So yeah, I share that frustration completely.
But then I think, so certainly in my patch, in my area, just even in the last 6 months, where it's quite frustrating when neurodiversity is being looked at, and when they often talk about neurodiversity, it is ADHD, autism, and I think they just kind of say that like it's one word. But certainly in my patch in County Durham, there's a director being tasked with valuing diversity in Durham County, and she has fully accepted that is not possible if we are not looking at FASD as well. It's not possible to value neurodiversity without FASD. So we've got a separate little task group going on there, which I'm part of, to start and look at where we are, what's happening. So it feels like it's like all doom and gloom, but I am in the trenches, literally physically in the trenches, and I think if I can see the positive, what's ahead of us, then anyone can. But I just think that it is frustrating, and I don't know, but I know that I'm going to be using this report now to, I love, this is the part of my job that I love, where I'm not scared to cross the line between being a mother, but being a professional, and holding the mirror up and saying, okay, then so these are results for our patch, so this isn't very good. What are we going to do about it? And I think that's all of us can do, really. Keep chipping away at that. I think I'm not just trying to. Sometimes I think people bring me in to try and be like, oh, Claire, put a positive spin on things. You'll always make someone smile about it. But I genuinely feel like this about it. So I don't know if anyone's got any other questions, or because I've got to nip off in a couple of minutes because my middle boy is on a driving lesson, and I like to be there when he pulls up.
No, and I think, Claire, you said what a lot of us are feeling, and I do remember when, as I said, we were the lay people, the family people on this nice quality standard committee, and when the quality standard came out, we were just a little bit gobsmacked, weren't we, that it had gone further than we thought it might do. And it's not to say any of us are naive or don't understand the challenges, but what I take from the fact that here today we've had close to 90 people at one point on this call, probably half of them from NHS organizations. That wouldn't have happened a couple of years ago, before the nice quality standard, before the needs assessment. So things are changing, and it's really important to keep that in mind, although there are people, when we have to recognize, families in crisis right now for whom it's not changing fast enough. we have a couple minutes left. I wanted to just give Inyang a chance to finish her thoughts because her technology jumped off, and then to just give Raja Mukherjee, who's joined us, a moment to say a final thought or two. Inyang, was there anything that you desperately wanted to say before the technology cut out for you?
Yeah, no, I've listened to comments by, comments that were made about the difficulties with doctors finding it, saying they want it commissioned, and if it's not commissioned, it's going to be very difficult. I think that's one of the things that kind of drags things for us. I've been in this county, I have sat in many, many task and finish groups with the commissioning team. And I just got disillusioned because many times when you talk about commissioning a new service, it drags so much that you end up, things don't happen. And so, although, yes, we need to push for commissioning, but I think that at this time we're pushing for commissioning, children are suffering, and there are changes that we can make within our services just by simply doing what we've been doing, but having an expanded thought about how can we work across the board with different professionals to say, can you look at this child when I'm suspecting FASD, is it possible for you to do X, Y, Z, assessments when you're looking at them to give us that information? I think commissioning takes a long time. I don't want to go into my woes of commissioning, but I think it does take a very long time. And I think that we need to be going into this in ways where we can improve on what we're doing to give more children access to being, getting on, because the diagnosis is just one thing. They need to move on from the diagnosis and actually get the support. We do, it's not the diagnosis is not going, we need the diagnosis, but we need it quickly so that they can move in and get the support they need. And they can't afford to wait for so long for commissioning.
And I hope if there's one thing that people take away from the report, originally we were thinking we would call it like hot potato. It's that referencing that children's game where you're holding something so hot so you pass it on to somebody else, and it's somebody else's responsibility next. And I think what we're trying to say is that for the changes and the improvement in the quality of services that are called for, both in the needs assessment for England and the nice quality standard, it needs, and even what's also in Sign 156, Scotland doesn't get a free ride on this either, that we need across the board everybody to understand that FASD is relevant, and that includes the prevention side of it. It's relevant for everyone to take this on board. Raja, are you there? Would you like to say a few words?
Sorry, I'm late to this. It's my first day back from being on holiday, so there's loads of catch up to do. So I hadn't said I would join unless I could tag along. So I've missed much of it. So sorry if I'm saying the same kind of things. That the thing that's
introduce who you are first, maybe not everybody.
So. Okay, so for those who don't know me, Raj Mukherjee, I'm the consultant psychiatrist, professor of psychiatry here in Surrey. I started the National FASD Service in 2009, and I work closely with many people who I can see on the screen already. And I've been on the NICE Quality Standards panel and various other advisory committees. We've just finished writing the Royal College of Psychiatrists guidance on this, which is going through the college processes now and hopefully will come out later in the year, which will be another document which will be useful for people to know where FASD fits into the bigger scheme. But I hear this all the time, and the biggest thing that we need to say to people is you are already commissioned to see people with neurodevelopmental disorders. You are already seeing FASD cases, just recognize them first. Because even if you do find that, I went to a commissioning event where they talked about how do we deal with the huge demand that's coming on neurodevelopmental services. Well, let's prioritize certain groups, and the groups that they're prioritizing will be FASD groups, whether they think they are or not. So it's getting people to simply recognize who they're already seeing because then you'll find actually all of a sudden you've got enough cases that are recognized that you have enough capacity for a day a week, and all the type of tests that you do will benefit anybody with a neurodevelopmental condition. I think that's what Inyang was implying just before when I was listening. And there are things that we can do which will make a huge difference. Nobody quibbles if somebody sends them for a blood test or they send them for an x-ray. So why would you quibble if you had another £2 evaluation, which is going to give you information that will help this individual for the rest of their lives? These are the arguments that they need to understand, because people think it's something different, it's something new, and nobody's going to do something new when they don't have capacity to do what they're already doing. So we just need to get people to recognize you're already doing it. Let's make your life easier. Let's make it helpful for you to actually find what works for these individuals. Therefore, you can actually do something good. And that's the starting point, which people are more willing to listen to than to hear, give me something new. And it's a hard message to get through, but the report's going to be really useful in terms of just driving people to say, look, you've had 2 years already. What are you doing about it? It's sort of COVID is over, even though I've got a cold. It's not COVID. I've tested. That it's very much the case that we now need to start moving on. We have a new government who are going to do a review. We need to work out how we fit. I'm sure you've talked about all this. And then we're going to work out how best to get the needs of this group met. Because, I've been doing this 20 years plus now. And there's a few people on the screen, Joe's smiling, who's been doing it just as long. And we've seen a lot of movement, and I see this very much as a cup half full, is that we've gone a long way and we've achieved a lot, but there's still a way to go. But as Sandy was saying, you wouldn't have got 90 odd people in the room. When we wrote Time Is Now together, we wouldn't have got all those people in the room together to be able to engage with this. It's a really important point in our journey, but the momentum has to be carried on. And this report, it can be used by people to highlight, you know what, don't go to sleep. This is time to do something about it. I'll shut up.
Now, thank you very much, Raja, for all really good points. And again, going back to where we started this whole discussion with, we recognize that there are people of goodwill across the NHS trying to make change, trying to improve the quality of care. And it's just so important that, we work together to do that. And I'm just going to, if I can find the right slide to do this. We have, we'd like to ask all of you who are here to please just take a few minutes. I know that you haven't had a chance to necessarily contribute in an active way. This is a really quick and open-ended feedback form where any advice that you have for us about the report or about things moving forward, or any questions that you have, we'd like to hear from you. I think this link is being put into the chat as well, in case you don't have a smartphone on you. And while people are looking at that, I don't know, Róisín, did you have any final thoughts or anything that you wanted to say?
No, I just echo that it's fantastic to see so many people interested in, hearing about the report. And what's important now is that people take on board what the findings are, and actually go back to their local authorities, their ICBs, their trusts, instead of saying, we're supposed to be doing this, we're not, and try and move this forward.
Thank you. And you had mentioned Mandy before. Mandy, I imagine you might be on there. I don't mean to put you on the spot, but if there was any words of wisdom you had for any area that wanted to get moving and you feel like jumping in and saying hi, now would be a time to do that.
I think everyone needs to set up some sort of steering group with all the partners in the city. What we did in Sheffield was we did that, and then now we're South Yorkshire, and now we're moving to Yorkshire Humber. And I just think it's a way of sharing what works and what doesn't work, and it's just a way of getting people together. Thanks, Sandy.
Thank you, and thanks to everybody who's doing all of this great work. The change is happening. We can see it, we can feel it, but now we just need it to be more joined up, and we need everybody to understand that it's relevant to all services, and it's not just a tick box. The nice quality standard was not meant to be a tick box exercise. It's meant to show the improvement in the quality of care over time. So if your area is one that considers itself compliant, maybe have a look again, look at the indicators, look at the nice form that they provide for areas to see how they can track indicators. Because we were told as members of the committee that if after a certain period of time, all of these measures are being met, they'll reconvene the committee and we'll put in new ways that things can be improved. This is meant to be a dynamic, ongoing, growing, moving exercise. And there are so many people. I'm pleased that my colleagues from the FASD UK Alliance have been messaging in the chat. There are groups all across the country who are willing to work with their local trusts and boards to bring about the change, so you can have that family input, the people with FASD. You know, there's so much more that can be done, and we all stand ready to work with you. So thank you. We'll end now. Thank you for our patience in going a few minutes over time so that we can, due to the delays that we had with some of the technology, but we will stop this here. So thank you, everybody, and good wishes. It's important work, and it can really change lives.